All right. Well, thank you so much for being here. Again, I will really encourage you. Please interrupt me. Please add questions into the chat. I can see it as I'm presenting. This is meant to be a pretty brief and pretty informal session to share with you what we currently know about the upcoming health-related social needs benefit. So I am going to go ahead and share my screen and jump right in. So maybe a show of hands, maybe some info in the chat. How many of you have heard of this already? Is this a completely new acronym in our healthcare alphabet soup? Maybe not a lot of familiarity. Okay. Yes. Beatrice has heard of it. Used to SDoH. Yeah. So, social determinants of health and health-related social needs are things that I am getting the impression are used somewhat interchangeably in other states and other communities. Health-related social needs can really just be a reference to the social needs that are related to health. In this scenario and the way that I'm going to be talking about it today, it is considered a specific benefit offered through Oregon Health Plan. So we understand the social determinants of health are impacting individuals' well-being, and we talk about a lot of things related to that. But in these kind of contexts, when I talk about health-related social needs, I'm really speaking to this benefit. So I will go ahead and dive in and we can talk more about it. Okay, so Medicaid in Oregon has a very specific waiver that allows us to spend Medicaid dollars on things that don't look like the delivery of healthcare. So the absolute favorite example that I think is used and that really has in a lot of ways led to the creation of HRSN is that if there is someone, say, living in a mobile home and they don't have air conditioning and they have a serious heart condition, they keep going to the emergency room because that heat is exacerbating that condition. You give them an air conditioner, they stop going to the ED, and their overall well-being improves. That was, one of the original examples around why Medicaid services need to be able to adapt to needs in order to prevent healthcare symptoms and problems from happening or getting worse or starting. And so there are a lot of things that are involved in the waiver, and we've been under this waiver for 8 years now, maybe for a good number of years. But there's a new waiver that was applied for and is still in the very final stages of getting fully approved. And part of this waiver is really to expand that idea that healthcare is often mostly delivered and health is mostly improved outside of a clinic setting. And so the goals are to expand that, ensuring that people are really keeping their coverage, addressing the social needs that impact health, ensuring smart and flexible spending, specifically for health equity, and ensuring that the system itself is culturally and linguistically responsive. There are a lot of things in that waiver. The one that I think has been really the biggest topic of conversation and the thing I'm going to talk about today is health-related social needs. So this new benefit that is coming through. Okay, existing funding that CCOs in Oregon offer, coordinated care organizations in Oregon offer as part of their management of the Oregon Health Plan for their specific regions. So we talk about them in a lot of different ways, but the terms I'm going to use today are community benefit. So community benefit initiative funds are part of the overall health-related services, HRS, instead of health-related social needs, HRSN. there are a lot of acronyms and a lot of kind of tree branches here. But community benefit is the branch that is really meant to be for community-wide interventions or prevention programs. So those usually look like grants. So we give out grants to support things like food security, to support housing, to support social needs navigation. A lot of kind of education and outreach activities are falling under community benefit. The difference is that it is not an individualized benefit. It's meant to be broadly for the community. Those requests will come from an agency and they are not specific to an individual. They're really specific to the broader population to improve community wellness. So this can be a variety of things. But in contrast to Flex, it can be something like paying for a yoga class for a specific population for which those activities might be evidence-based or show evidence that it will improve health overall. So the CBI would pay for the whole yoga class that anybody can come to, assuming that many of the people attending that class are going to be on OHP. Flex, on the other side, would be paying for a specific class for an individual person as a part of their care plan. So with Flex funds, these are individual member supports. These are probably the ones that you all are going to be most familiar with. They are, again, provided to agents through agencies sometimes, but they can also be an individual request. If someone says, hey, I really want to go to this yoga class, or I really need this equipment that isn't covered by my health plan, they can submit a Flex request. So this goes through an individual request process. We review that case and then approve or deny according to a bunch of different criteria. And so this is available to all CCO members, but each individual item that might be approved is not considered a benefit. It's really based on that individual request, individual need. Okay, the new one that is coming through is looking a lot like Flex, but it is considered a benefit because there are individual items and services that are covered by Oregon Health Plan, assuming an individual meets a specific criteria. And I'm going to really dig into the details of that, but one of the really key differences is that it is a benefit. And so we will be working with community-based organizations. We will be working with housing agencies. We're working with Home Depot and Lowe's to make sure that these devices and these services are delivered as a benefit according to most of the other rules that we adhere to for delivering the health plan benefit, like healthcare services and procedures. Okay, any initial questions before I dive into the detail? Okay. So the things that are going to be covered, and this is over the course of about the next year and a half, will be climate devices. This is the only thing that is rolling out at the beginning of 2024. So in March of 2024, we will see this specific benefit go live only for climate devices. And I'll talk more about those. And then later there will be housing supports and then nutrition supports and education. And the entire time, some degree of navigation and outreach services will also be considered part of that covered benefit. Okay. So here's the timeline. We are going live with the climate benefit in March of 2024. So still in that first quarter of 2024, this will become a benefit, and any submissions, any requests for climate devices will likely go through that HRSN process. And then in November, we will be going live with the housing benefit, but it's really going to be only limited to people who are at risk of losing their housing. So it's not going to be providing housing vouchers. It's not going to be providing shelter supports. It is really narrowed to those who are currently in some kind of housing and are at risk of losing it. And then I'm noticing that this is numbered wrong. 2024 is climate and housing. And then in 2025, there will be the housing benefit will go live. The full housing benefit will go live at some point at the beginning of 2025. And then the nutrition benefit is also going to go live at the very beginning of 2025 as well. Don't pay very close attention to this slide. I will also share, and I'll talk about this a little bit later, is that we'll be able to release community capacity building funds. It's a big lift to be able to deliver health plan services to a community. And a lot of the agencies that are going to be delivering these services, housing agencies, food pantries, agencies associated with navigation and even traditional health work, don't necessarily always have the infrastructure to support this kind of work. And so we're going to be releasing some funding that is coming through OHA to make sure that the infrastructure is there. So when you're referring patients for a service, they are successfully receiving it. Okay, so very briefly, and to be frank, we don't have a whole ton of data around the housing and nutrition benefits yet. And so I will share about this very briefly, but rest assured there will be more webinars, there will be more info as it gets closer to the go live date for these benefits. So housing, the idea is to reduce the risk of homelessness and reduce housing instability and homelessness in 2025. So the services that will eventually be covered in 2025 when the full benefit goes live would be rent and temporary housing, utility costs, pre-tenancy and transition navigation, tenancy sustaining services, so staying in housing, one-time transition and moving costs, and then home accessibility modifications or remodeling, essentially. Okay, and then nutrition. So this will align with anybody who is meeting the USDA definition of marginal food security, which is essentially a self-reported social needs measure. And the services covered would be medically tailored meals or pantry stocking, and then fruit and vegetable prescriptions, or VeggieRx is what we hear a lot. Okay. So the area that we have a lot of detail that is going live very soon and that I will really dig into today is around climate devices. So the goal is to address the health risks that are created by climate changing, including cold, heat, air quality, and natural disasters, things like power outages as well. So here are the social criteria for this benefit. I will share that the social criteria are going to be very similar for the nutrition and the housing benefit. We're not 100% sure yet, and so we know this absolutely applies to the climate benefit, but we're calling these transition populations, and they're the ones that are largely going to qualify for the HRSN benefit overall as it rolls out over the next 2 years. So these criteria, these transition populations, as you might hear, are youth involved with child welfare, people experiencing homelessness or at risk of homelessness, people who have been released from custody or residential behavioral health settings. And this is within the last 12 months. So we have kind of a big period of time with some of these transitions to reach out to these members and get them connected with resources. people transitioning from Medicaid only to dual coverage, and then youth 19 to 26 who have special health care needs. And that population will become eligible beginning January 25. Okay. So the climate devices that will be covered, there are only 5. This benefit is 5 devices specifically. It can kind of feel really big, but these are the things that would be covered that you would be able to refer patients to receive. So air conditioners, air filtration devices, home medical refrigeration, portable power, and space heaters. Okay, this slide is really busy. I will send out these slides with a little timeline correction, so you will be able to access this. And these kind of specific codes associated with these diseases, we'll be receiving those and be able to share those out as well. So it's a pretty long list for the clinical criteria to receive an air conditioner. So you can see these. It's going to look pretty similar for the next few slides, but I can certainly slow down if people have comments or questions. So it's a really wide range of conditions, anything from physical to mental and substance use conditions. There are a lot of things that can really qualify for people to use these. So there's the air conditioner, a slightly narrower range of diagnoses for heater eligibility. For air filters, again, even a little narrower. And then for the portable power supplies and the mini refrigerators, it's a very narrow criteria for those specifically. So only for those people who have DME that requires electricity or assistive technologies that require electricity to receive that PPS device. With all of these, there may be other conditions that are approved by medical exception, as applies to many other procedures. And then for the mini fridges, any medications that require refrigeration, if someone takes those medications, that would qualify them for this benefit, given that they also are a member of that transition population. So those are the 2 key pieces that people need to qualify for this benefit is, they've made the request, but then they fit into one of those social transition populations that were listed in the green boxes, and they meet the clinical criteria for this device. Okay. So the process right now, I'm guessing the thing that is going to feel relevant to you is, what am I supposed to do with this information? So as of now, still in December, we are not live with the HRSN benefit. So if you have a patient, someone you're working with who needs probably not an air conditioner this time of year, but if they need a heater, if they need a portable power supply, you can still request that item, but it would go through our existing Flex process. So you probably all have the form. I can go ahead and put the link in the chat if that's helpful, but you would submit through the same process that you always do. You can fax to our fax number. If this person is outside of that transition population or doesn't meet the clinical criteria, we will still review it as a Flex request and see if they qualify through the specific Flex process. And then in March of 2024, the actual benefit will go live and we will have a specific form so you can request the HRSN benefit by then. Okay. Questions there? Any thoughts or comments about that process? Okay. Are people familiar with Flex requests? Is that something people have submitted before? Worked with their colleagues to submit? I see a nod, so I'm going to say yes. Okay. I think the goal is really to make the HRSN process as streamlined as possible and as familiar as possible. Okay. So what will you or your colleagues as providers, as referring parties, as MAs need to submit to us? This is going to look really similar to Flex. So we obviously need their name and Medicaid ID, probably a date of birth, the identified need. If you can identify that transition population criteria, like, hey, I know this person is in foster care. I know that this person is at risk of homelessness. That is a huge help in helping us to verify. And then what clinical criteria do they meet? So same with Flex requests, we would need documentation, evidence that they meet that clinical criteria. We'll check it on the back end. And then the last piece is evidence of existing resources tried. So it might be maybe this person is dual eligible and they've been working with NWSDS to try to get them an air conditioner, and WSDS couldn't provide one because they didn't qualify. You would want to document that to make sure that we know all of the other resources have been explored first. It might be we called YCAP and we weren't eligible, or we called some other kind of social needs agency and nobody answered. There's kind of a range of what that evidence might look like. Just do your best to provide that, show that you were asking. Okay. And then this is just to share within that community capacity building funding. So building that infrastructure so that once we get into that nutrition and that housing phase, we will be able to provide supports so that those services can successfully be delivered. Okay, so I already see a question in the chat. Yes. So Bailey, when you say screening patients for benefits, do you mean within the OHP application or screening once we receive the request? Yeah. So within the OHP application itself, there currently isn't a self-identification of social needs. That's just not part of that state level process. One thing that we do is we send out something called a health risk assessment. And that asks a variety of questions about different risk factors. And among other strategies for screening for social needs overall, that's something that we can do, is send out screening forms to members once they become eligible for YCCO. We're also looking at ways to work with some of our community partners who are working regularly with clients to make sure that they are screening for social needs and all that data is able to be centralized. So that's kind of a parallel process that's happening. So we have a better understanding of who qualifies within these transition populations without, needing it to be identified every single time. For now, it's always helpful with a referral that we have that information. And then we would also, our care management team would also follow up within those specific referrals. So we would receive something, we have the information we have. We would verify as much as we can on the back end, make those calls, but the process goes much more quickly the more complete that request form is. No, we maybe get like 15%, maybe up to 30 if we're really lucky. It's a pretty low rate of return. So we definitely need to be exploring other avenues too. What other questions do you have?
Emily, I have a question.
Yes.
So my understanding is the HRAs will be mailed to us from the members. Is that correct? And that's
Yes.
how we're getting that information.
In the
When
mail.
we get a referral from one of our partners about a member, we are calling them without the HRA. Is that, do you know what I'm saying? Like if someone, I want to make sure I understand the process. So if someone from, wherever calls us and says, I have a member that I think could use case management, and we don't have an HRA, can we contact the member and do an HRA with them? Or I want to make sure I understand the process.
Yeah, I don't see why not. I will say we haven't incorporated the social needs screening into the HRA yet. It has some kind of social questions. But what we can do is explore having care management do social needs screenings. I see Jean is raising her hand. She may know more about this than I do.
Right. And I think even when we're doing the HRA, we can certainly ask questions that may not be on the HRA to try to determine need. And keep and document that in the interactions. I just didn't know if there was a specific way that we would do it if we were getting a referral from some source other than an actual mailed in HRA.
Yeah. Go ahead, Jean. You're off mute.
So Michelle, we haven't completely worked through the workflow process. That being said, there will be a flex fund form is already in process, and we already do it if it's a member not in the transition population. If the provider or a member believes they qualify and they're a transition, they're one of those populations that Emily showed, they fall under one of those, then there will be a form with what their need is. And included in that form is required from now on that the member has to agree, yes, I have this need, and yes, I agree that my provider can send this to our CCO, to Yamhill CCO. They have to say yes to those. Not just I have a need, but that yes, I agree. So they will be expecting a follow-up call. And from there's going to be an eligibility form that has to be completed with further information from the team. And we're hoping that there will be an initial person that receives that within our CCO. But we're not sure yet. It could go to the care management team, whoever receives that. And then from there, it will be determined if they do, in fact, fall under that transition population. And these benefits are the one thing that's different is they have to go through an approval process through and not flex funds does not have to go through per se. So that's another process that will happen there. And so, that's how we plan to move that forward. Going forward. Also, sorry, one other thing that I'd like to mention is when a member when a referral comes in and the need is identified and approved, say for housing, a care plan is required. So that member will be tracked and a care plan is required, which is what Emily said earlier, that we will be contracting with other community-based organizations to do some of that case management. So Bailey said, who does the care plan? So the CCO will have to have a care plan, basic care plan, but the the organizations we contract with, say for housing or food, they will have case management. They will have to provide case management to that member, and there will be codes. This is different. This is why it's different than flex funds. There will be codes that the provider can get reimbursed and invoice us, the CCO, for those codes and for those services. So they're working on those codes right now, which is why it's still out until November. They're just focusing on the climate devices. Doesn't require as much case management, but it does require a check-in, I believe after 6 months or something like that. Yeah. That's a very good question, Michelle, and we've asked that too. Can they refer? Can they request it, deny case management, and still require? Now, I asked that. I think it has to be documented, but I still think they would get a device. Yes. That they haven't come out, yes, and said definitely for housing when they request or when there's a need for 6 months of rent. That's one of the benefits that housing will provide. If they decline and say, no, I just want my rent paid, I don't want to partake in case management or my care plan. We're still trying to get that solid in writing from OHA. But hopefully that will be very clear before the benefit starts.
And Bailey, can you talk a little more about what specifically, or what many things specifically, are going to be barriers in primary care? Make sure the care plan is visible and updated. Yeah. And that's part of our adoption of a new platform, Helios. We're integrating a lot of these systems to make sure this information is more visible. So the consent form is going to be the barrier. Yeah, so it wouldn't have to be a signature, but just this kind of verbal consent, like, can I make sure you have an air conditioner? Okay. So if people aren't seeing the chat, so Bailey is sharing that getting patients to sign something about their needs and making sure they're okay with us sending it to the insurance. Most of the time we identify patients when they're not in the office. Is that true for other clinics? I'm maybe just seeing, is it just Vici otherwise?
Hi, I'm Dana. I'm with Virginia Garcia. I'm with our enhanced care management team here. I think for our patients, our team is community-based, so there is a lot of visits and going out to see patients, but I think in terms of like identifying needs, a lot of that maybe happens like by having a warm handoff with the patient here in the clinic, or having a phone call or hearing something from the provider. So I would say it's kind of a mix, but that if there was a need identified, I think it would be pretty okay for us to be able to kind of get the needed things done, or even doing that in a home visit with the patient or things like that. I'm not sure if that's kind of what Bailey's referring to, but.
Okay.
Hi, I'm Maria. I'm from Virginia Garcia, Newburgh. I feel like it happens maybe half the time in the office and half the time we are doing those screenings and things over the phone, because sometimes, depending on the situation, it's hard for the patient to get in, or they don't feel comfortable with someone coming to their home. So sometimes we're able to get signatures, and sometimes we have to kind of work around that, and that can put a time restraint on getting the request in faster, because they're either unable or unwilling to come in due to their situation.
Yeah. If there wasn't a signature required and it could just be verbal consent, is that still a barrier to have to sort of make that call and have that conversation and give them that kind of canned language?
No, I think I think it would be easier if a signature wasn't needed from them. Because a lot of times they are
Yeah.
more than willing to accept the help. It's just sometimes there's some barriers to getting them in.
Mhm. I think in the form there will be a signature, and also member has agreed, to waive the signature, but agrees to allow referral to be sent to CCO. And this is actually in protection of the member. What providers or CCOs have experienced in the past, and members go to their provider, they trust their provider, they share information. They're not told it's been referred. They get a call from their health plan, basically, and they say, "Why are you calling me? Don't call me. I'm fine." And they don't know that referral was sent on. And so this is just another step for them to have that voice and that approval that, yes, I have the need, and yes, I want you to follow through.
Yeah, that makes sense for them to give the okay to move forward.
Yeah, Bailey, I appreciate this feedback. That's helpful. We're definitely hearing like, yeah, people feel very sensitive about, talking about these kinds of needs. So we want to really prioritize that and be mindful.
Yeah. And another adjustment, you all, that our members, because of this benefit that they will have to adjust to, and I've been thinking a lot about this. When you need food, when you need some help, and you can go to churches and you can go to different community-based organizations that don't require a lot of information from you. And that's really important for many people. They don't want to share a whole bunch of information. And yet, if they agree to having this as a benefit, so it's just like a medical claim, right? It starts to be medicalized. We need to ask much more information. And I've been grappling with that a lot of, okay, this is going to change. And some members may say, forget it. No, like Michelle said, I don't want to be part of it. Forget it. And we have to document, we have to also tell them that that's their choice, and it's available if they need it. And if they change their mind, it's here. But we have to honor that they may not want to provide additional information about their situation or their life or themselves. But there is more information that's going to be required. And then we have to report to OHA on every service that we reimburse a CBO that invoices us, and show that exchange of claims and funding.
What other thoughts or questions do people have? Is there more feedback about that process? So we need the consent. Are there other formats or requests that you would have as we develop this form? Yeah, it always takes time to work through the issues. Continuous quality improvement. Yeah, so Bailey asked, is this something the case managers could do, like a home visit for patients at high risk for social needs? So I think that this is going to be what those community capacity building funds will support, as well as the navigation part of the benefit. So we're providing that case management. That might be a home visit. It might be, a more like central visit somewhere that isn't a clinical space but isn't a home. I think that there are a lot of options. It is going to depend on those agencies and their capacity to offer that kind of case management, and in what structures that they already have where they would do that. But I think we could definitely keep home visiting models in mind and encourage them, because I do think they're really effective, especially for, certain populations. Oh, I think that's not completely off the table, but I would say generally our case managers wouldn't be doing home visits. Bailey asked specifically the YCCO case managers. The clinical care manager will be. Thanks, Tammy. I'm glad you're here. And then Tammy, you also asked, can we get feedback from members? So we have a couple of pathways for this. We have been developing policies around doing screening for social needs specifically. That's really that first space where the member is going to encounter, the process of accessing this benefit. And so we've had some conversations with a parent advisory council, with our community advisory council, to try to understand what that piece will look like. Some of the feedback we've gotten is really, if you're going to screen me for something and I have a need, you need to be able to connect me to meet that need. A lot of times, people are saying, I can't afford my rent, but we're unable to find them more affordable housing because there simply isn't any, and they have to get on a 5-year waiting list. And so that's something that we've been hearing really loud and clear, is that if there's going to be screening, that we need to provide resources to address the needs that are identified. So one of the things that's been in process is developing a resource guide. We have an existing one that is shared with Polk County, but it's in its revision process right now, and we're doing some work to make sure it's really updated and has current and applicable resources in Yamhill County, as well as Polk County. And then Tammy, we're going to be in the process of doing different kinds of community outreach and engagement, including listening sessions and surveys, things like that. That's kind of part of the work that I do on the other side as well, but we're going to be asking lots of questions about things that would be relevant to HRSN. I get excited about that kind of thing, so I'm glad you asked that. Yeah, so a comment, in-home visits give a much better and more realistic view of what patients' needs may be. Yeah, absolutely. I appreciate that feedback, and I'm gonna take that back to the team. You're fine. I love it. This is what this was for. Anything else? These have all been incredibly helpful questions and comments. This was also meant to be an opportunity to kind of give feedback and make sure that people are involved in this process as we continue to develop it. Transportation added. Yes, so the well ride benefit will continue to apply, and well ride is transportation to any covered benefit service. And so if they needed to go to an organization to receive those covered kind of outreach, engagement, navigation services, that transportation could be provided and requested.
But that is for all members. So it's not, transportation is not one of the things identified for just the HRSN population. That still is covered for any member, the well ride. Yes, they do need advance notice most of the time to accommodate.
So if there were other urgent needs, and I think the only example I could think of would be like if someone needs emergency shelter, maybe that's what you're thinking of. There wouldn't necessarily be a guarantee because WellRide isn't emergency transportation. It's non-emergent transportation. But they really do try to accommodate things as quickly as they can. I know there's just been a really significant shortage of drivers. That's been the major thing that we've been dealing with recently. It's not so much that, they don't want to provide services faster. It's that they just simply don't have the providers. Yeah. I think the best I can say, Bailey, would be they would certainly try and someone could call and request that trip. But I think that just with the service capacity, that may not be possible when they're also taking people to the hospital and to procedures and things like that. If anyone wants to refer drivers to our WellRide network, yeah, Dial-A-Ride would be another option. I'll just share kind of on the side. So Yamhill County Transit Authority has been in process of developing a kind of new strategic plan, improvement plan based on a lot of community feedback they've gotten. And Dial-A-Ride was one of the kind of top requests. So I don't know exactly what work is happening there or on what timeline, but I do know that Dial-A-Ride is a really good service, and the Transit Authority has certainly heard that expansion could be really helpful. Yeah, Tammy, that's true. And that's a space where some of those navigation supports could identify, maybe a more walkable food pantry, or if they can't walk, other kind of delivery options. Yeah, so I will send out the link to the community resource guide. Keep in mind, it's in the process of being revised right now, so there will be a newer version. And if there aren't things that meet those needs, I know, to be honest, I know that there aren't a lot of kind of emergent social needs responses. I know Encompass Yamhill Valley does a really nice job of being pretty responsive to needs, but again, they're kind of limited by their capacity. That would be the one that would come to mind for me. I don't know, Tammy, if you have other thoughts or recommendations.
I'll just unmute. I know if they're tribal members, tribe does a great job of, if they're a tribal member, even if they don't live in Grand Ronde, their community, in fact, I just came from their office, the community office will assist in delivering medications. Their food pantry program will do box deliveries. So if they're tribal, there's some great resources. I know VA, sometimes VA does have drivers. In fact, I have a dear friend whose husband is the coordinator for that program out of Salem. So if they're VA members, there's a lot of great resources. If you reach out to the local chapter of the VA and let them know they have a veteran in need, they can help assist with transportation, maybe delivery of foods or meds. I know sometimes St. Vincent's and Salvation Army can sometimes deliver if needed. You know, and even, and we're still ironing out what I'm going to be doing. And even if there's times that even if I'm in contact with a member, you know, I can also help coordinate some of those resources as well. If I'm in, you know, but we're still ironing out my position. So I don't want to commit to anything until I know where I'm going to be on that. But there is the VA, the tribe, Salvation Army. There are those out there. 211, sometimes you can reach out, and if they let them know. And I remember, and like you said with, well, right, there was some medical transportation or transportation with the county, and it had to be 5 miles, within 5 miles. I know there was one where they would pick you up at the door and transport you, but it had to be within 5 miles. But that was pre-COVID, so I can't speak to that program if it's still existing.
I just put the resource guide in the chat. I would welcome feedback about anything that's missing, because we are in that process of revision right now. Shout out to Tammy. Yes, we're so excited to have her. Okay, well, if there is anything else, as questions come up, please feel free to reach out directly to me. I would be happy to answer or connect you with somebody who can answer any questions I can't. There will be more to come, and I really appreciate you all taking the time to learn about these first stages of the HRSN rollout. And hopefully we will be in touch as it continues to be successful. Yes, Dana, the session tomorrow will be a repeat. So certainly you could join near the end if you have more questions, but it will be the same content. Okay, well, thank you all for your time today, and I'm sure we'll be in touch, and have a lovely rest of your Thursday.
Bye. Thank you, Emily.